Thank you for joining us for the fourth annual Global Summit on Kidney Innovations and Global Kidney Patient Voice. The key to accelerating innovation, a collaborative partnership event presented by the American Association of Kidney Patients and George Washington University of Medicine and Health Science. Hello, I'm Lana Schmidt, and I am an AAKP board member and ambassador for the state of Illinois. I'm also a kidney patient, having experienced all dialysis methods and was on home dialysis before receiving a kidney transplant in 2016. I'm currently retired and mentor kidney patients throughout the U.S., helping them through the kidney disease process of dialysis choices and the transplant journey. As a national kidney patient advocate, I have served as a board member on committees and in many other capacities throughout the U.S. I have raised kidney awareness from the patient perspective through publishing many articles in magazines and newspapers, doing TV and radio interviews, and speaking at conferences and meetings on kidney disease issues. I also started a kidney patient support group in my area. I was diagnosed with a rare disease, Goodpastures, and I have been involved in PCORI and other research programs. Being part of AAKP allows me so many opportunities to share my patient voice and experiences, especially within the government, meeting with government officials and lobbying for kidney legislation, and also for participating in kidney patient-centered research. As an AAKP member, you can do the same. It's critical now that we as patient consumers raise our voices and create the demand for new diagnostics, devices, and biologics in our independent countries. Through AAKP Global, launched in 2019, AAKP is engaged internationally because we're committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new innovations in treatment, and the opportunity to save more lives. We believe that a united patient voice can drive innovation and the policy decisions that determine timely regulation and payment for new and safer care treatments. Globally, we're working with patients, medical professionals, researchers, and medical industry allies to cultivate a united consortium led by patients. AAKP believes this international consortium can advance innovation and change kidney care in countries where healthcare systems and the infrastructure do not support consumer choice and access to care treatments. I am now pleased to introduce another good friend and AAKP ally, Tom Duvall. Tom is Division Director of the Division of Special Populations and Projects at the Center for Medicare and Medicaid Innovation, Centers for Medicare and Medicaid Services. We're honored to have him with us to share about new care models for the U.S. Tom, I now turn it over to you.
Hello, everybody. My name is Tom Duvall. I'm here from CMMI. I'm very excited to talk to you all about some of our efforts related to home dialysis and wanted to give special thanks to AAKP for having us today and for talking about this important issue. I want to start off with the goals, because the goal is not necessarily home dialysis, but the real goal is working with patients to figure out how they define success, which means not only dealing with the clinical symptoms of kidney failure, but also about what is their desired outcome, what is their desired lifestyle, and how can renal replacement therapy best align with those goals. And in an ideal world, we have a system where the provider, the nephrologist, dialysis facility, and other clinicians works with the patient so that the treatment plan really aligns with those goals, that there's extensive discussion about what the patient wants and how to best achieve it. And then that on the payer side, i.e. Medicare for the most part, and us, that we set the payment rates, the financial incentives, and the quality measures such that we can really achieve those goals that the patients are really going for. So that's what it looks like in an ideal world. And where we fit in at CMMI is really trying to better set up the provider to really get those goals for the patient. One of the things that's become clear when talking about home dialysis and really the larger context of renal replacement therapy is the disconnect between patient preferences and what we really see on the ground. So, and this comes in multiple different forms. That, according to some studies, up to 85% of beneficiaries are eligible for PD. So there's a very large eligible population who are not getting it at this point. There's also the idea that, according to a different study, 42% of patients preferred PD at home when all the options were presented to them. So that's what the patient preference was before starting dialysis, as opposed to obviously a much smaller number of folks who actually dialyze at home. And finally, among nephrology professionals, so those who are obviously dealing with dialysis every day, know what all the different therapies look like, then more than 90% of nephrology professionals chose a home therapy as their preferred treatment option, with a pretty big split between home PD and home HD, which is obviously very different than the 15-ish% of patients who dialyze at home right now. Home dialysis also definitely offers a lot of benefits for certain folks. It's a flexibility, it's a greater ability to balance dialysis with your life needs and a greater ability to work. And it can often help out a lot of patients who may not be getting it right now. And I think within the larger realm of patient preference, we also see this on the transplant side with over 100,000 plus patients on the transplant wait list. These are all people who have sort of indicated that they would like a transplant, but are obviously not able to get it right now due to supply constraints there. So why does this disconnect exist? And we have to really look at the why in order to then think about how CMMI and other payer solutions can really fit in there. So the first is the unplanned dialysis starts. Approximately 1/3 of patients who start dialysis didn't know they had kidney disease. A lot of folks, far too many, frankly, crash into the dialysis. They go to the hospital feeling bad. And in general, the patients who don't receive care for CKD and those who crash into dialysis are much, much less likely to dialyze at home. They start in center and then remain in center. Another issue, and this is one where CMMI and CMS policy can make more of a difference, is some of the lack of provider support for home dialysis, about resource allocations, about patient education that is often lacking, and as well as the financial incentives that are created for in-center care in terms of the way that nephrologists are paid, and in terms of the way dialysis facilities are paid, and in terms of investment in capital equipment. Another area that's a little harder to deal with is some of the social determinants of health that can really prevent people from dialyzing at home. So whether a lack of care partner, unstable housing situation, that there are ways to address, which are obviously quite difficult there. What CMMI's big model related to home dialysis is called the ESRD Treatment Choices Model, or the ETC model. And what the main goal of this is to say, what are the effects of payment adjustments for nephrologists and dialysis facilities on encouraging increased utilization of home dialysis? So our challenge there is to try to adjust the payments for both in order to see if that will ultimately affect and change the rates of home dialysis across the country. It is a model test, so it's a temporary one where the first payment adjustments went into effect in January 2021, and they will go until June 2027. And the way the model works, it's two different sets of payment adjustments. The first is the home dialysis payment adjustment, which is a positive-only adjustment on home dialysis claims for nephrologists and dialysis facilities. Those went into effect starting in 2021 and will phase out by the end of 2023. The second one, which is larger in magnitude, is the performance payment adjustment, which is a positive or negative adjustment on all dialysis claims based on the nephrologist or dialysis facility's home dialysis and transplant rates. The idea of that is that it is an adjustment based on performance, and that it is larger in magnitude and positive or negative, and is really meant to incentivize improved performance in those areas. So the combination of those two payment adjustments are the main pieces of the model, but we also include additional flexibilities about delivery of the kidney disease education benefit and a learning collaborative that's focused around organ procurement organizations and transplant centers with the goals of increasing rates of organ recovery there. The way that the ETC model works is on a lagged basis. So looking at the chart here on the right, we measured for the PPA, that upward and downward payment adjustment, we measured performance across the 4 quarters of 2021. We took a few months for claims to come in and then some time for us to run calculation. Now in July of 2022, the first claims are being adjusted, and they will be adjusted for the next until the end of 2022 based off of the performance in 2021. Then starting in January 2023, the next round of adjustments will occur based off of the performance at the end of 2021 into 2022. One thing that's unique about this model is where it is located. So it's a mandatory model, meaning that nephrologists and dialysis facilities are required to participate. The way that it works is that CMS chose a certain number of geographies, the ones highlighted in blue on the map, where nephrologists and dialysis facilities will receive these incentives. They were chosen randomly, and they may not be the blotches that you're used to, but they're what's called hospital referral regions, which is imputed based off of Medicare claims data to show where folks within a given region all go to the same set of hospitals. So CMS randomly chose 30% of the hospital referral regions across the country, as well as the majority of those within the state of Maryland, in the interest of giving us the best possible sample for testing. And we're going to be able to use this to really evaluate the success of the model and see how it works in these geographies and be able to compare to the other 70% of the country. We've gotten our first round of initial results from in summer 2022 here, and have made the first round of upward and downward adjustments for the dialysis facilities and nephrologists. Ultimately, we're going to keep going through this cycle until the last round of payment adjustments ends June 2027. Hopefully before then, we'll have some more comprehensive results, so we'll be able to see what the overall effects were of the model and really see how effective was this, and is this something that we want to build upon. Ultimately, what we're interested in is, does this have the effect of increasing the rates of home dialysis and transplant waitlisting across the country? And I think we're just very interested to see what the results look like. We're also operating the Kidney Care Choices model, which is more coordinated care focused, but I think also includes some key model provisions that relate to and can really help folks with home dialysis. One is that we're increasing nephrologist monthly payments for managing a home dialysis patient. The goal here, it fits with that same idea in the ETC model of testing out the effects of payment incentives for home dialysis, and if that will increase a focus of nephrologist education there. Another key focus of the model is an increased focus on chronic kidney disease, with the goal and multiple quality measures around planned transitions to dialysis. As we've seen before, that there's a clear relationship between folks who get care when they still are at CKD stages before they transition onto dialysis and being able to start dialysis at home. And then we also include quality measures for folks who begin dialysis at home. So it's really trying to hit it through a lot of different mechanisms within the model, within the larger context of supporting coordinated care. So now we're beginning to look at what this means for the future and how we can really evaluate what the models are doing, as well as how we should adjust to the underlying environment. One interesting piece to grapple with is the idea that home dialysis rates are already increasing. We've seen it go from about 11% to 14% over the last 2 years. And the interesting question there is why. This has been both across home HD and PD. So obviously there's been the pandemic in there. There was the announcement of these models as well as the beginning implementation of them. It's important for us to know and figure out which of these factors can most aggressively lead to this increase and this measured increase in order to see what the ultimate effects are of the models. And we conduct a big independent evaluation of the models to really try to disentangle all these factors and figure out what the causes really were. Obviously, the healthcare landscape has greatly changed due to COVID, particularly around home dialysis. And I think this is something that CMS is very actively evaluating to see essentially which interventions make the most sense and are really helping to drive this growth in home dialysis. Going along with that, it's how should CMS policy continue to evolve? Ultimately, our demonstrations that we test at CMMI are time limited. So our goal is to see, are they effective? Should we build on them? Should we just sort of cancel the effort completely because it was ineffective? Or should this be something that's expanded or incorporated into the permanent Medicare program? I think once we get results, these are the real questions that we're trying to figure out and determine the answers to. Another question is, what parts that are not addressed by our models should we continue to look at? So there's obviously issues around vascular access. That's something we hear a lot about making sure folks can get fistulas and PD catheters put in to be able to use home dialysis and effectively dialyze without a catheter. We also hear about upstream efforts before the onset of ESRD and are obviously aware of the importance of increased diagnosis and treatment of early stage CKD and definitely increasing referrals to nephrologists. Finally, the issue of just increased nephrologist education about home dialysis. How can we make sure that it's part of the treatment regimen for every patient? So where we are ultimately is I think we're in the middle of these tests, still definitely within the early phases, but I think we're optimistic about this rise in home dialysis. We think that more patients are being given this choice and being given a real option in their care, which I think we're very excited about. And I think we're excited to see what the next few years look like to think about how we can update and continue to use our policy levers to drive the best outcomes for patients. Thank you.
Thank you, Tom, for a great presentation and sharing your time and expertise with us.